what are some of the most common risk factors associated with using meth that we should be looking out for?
I would say skin infections, abscesses, also with like possibly sex trafficking or sex work, those types of things.
And then love Lauren's point. We can also talk about just like really basic like physical things, right? So people that are using crystal meth tend to stay up a few nights in a row, right? So you're up all night. So right off the bat, people are tired and people aren't bathing often. People are going to be dirty. They're going to have dirty hands and dirt under their fingernails, and they haven't slept or taken care of their teeth, right? You'll hear people use terms like meth mouth, which comes from your mouth being dried out, a lack of saliva, and then you're not brushing your teeth, right? If you're smoking crystal meth, you might burn yourself because you have to heat a glass pipe to an incredibly high temperature, right? So you might have burns on your hands, which can lead to other infections, right? If you're snorting drugs, if you're crushing the crystal meth into little pieces and then snorting it, people have damage to their nose, right? And if you're injecting, if you're shooting crystal meth, all the things that come with using, injectable drugs, right? So abscesses, other skin issues, cutting yourself, and then all the awful things that come with sharing needles or using dirty syringes, right? And ad infinitum, right? So you're staying up late, and to Zach's point, you're running with the crew, right? And if you're stealing bikes with a bunch of your buddies, things like fights and staying up late and bump-ins with the police, right? So anything you can imagine that happens to people experiencing homelessness or being on the street, but it's compounded exponentially by being up for 4 nights, right? So it makes for kind of a perfect storm of a lot of risky behaviors, right, that then compile.
But again, the risky sexual behavior, just anything with like cleanliness, sharing needles, sharing cookers, sharing pookies, pipes, all that kind of stuff is to be, explored and looked at and potentially mitigated if you can.
Right, so let's talk about that. Let's talk about, say staff are seeing these things, they're seeing this behavior or some of the harm that's coming from these behaviors. What are some strategies that staff can implement to sort of reduce the harm as, these behaviors are going to continue?
Well, again, like I said earlier, now we're passing out clean sharps. And so that to me is a game changer. And so, but that, passing out condoms, water, food, anything along those lines lets, the client know that somebody cares about them or somebody's paying attention. And so just that alone also is a help and mitigation, actually.
Providing primary medical care to people. They're oftentimes not aware of the kind of subtle injuries that are happening throughout, like, a lot of this activity, taking apart bikes and doing things, can lead to lots of cuts and then like lots of dirt and infection. And these are small things that can just blossom into huge things. And there's tons and tons of people out on the street who have had like gangrene and different kinds of infections that have gotten more and more intense as a result of not taking care of it. Basic first aid and basic medical care is really big for this population, I think, as is kind of basic mental health care. Having someone to talk to, like being up for 3 or 4 days in a row is incredibly hard on your psyche. Even if you don't go into a meth psychosis, it's just really, really tough on you. And when what goes up must come down. And this is a real common time for people to become really despairing, depressed. Oftentimes, like we were talking about, what do you do in meth psychosis? It's like you're not going to get an intervention in right there, probably. Like you definitely are better able to get an intervention in when somebody doesn't feel great afterwards. Where they're depressed and they might be willing to explore different options. But it's like there's opportunities in there. So sometimes people who use meth, it will trigger things like a manic cycle. And so it might not be that they're still high on meth, it's that they used meth and now they're into a manic cycle with because they have an underlying bipolar disorder. And these are things that are treatable, but typically not when someone's extremely high are they going to be willing to sit down with their psychiatrist and do an interview. But you can, like, you know, have these people available. And I think it's been really helpful to introduce things like people who are therapeutic adjacent. That's what I like to think of a lot of our clinical staff, therapeutic adjacent throughout treatment. So when you're doing outreach, there's people with you, and it's like, you know, I've had lots of people like, I'm not going to see a therapist. Oh, well, what about me? Would you talk to me? Sure. Well, did you know that I happen to be a social worker? I'm happy to talk to you. Oh yeah, I'll talk to you, you know, or I don't see a doctor. Well, what about this guy? Would you see him? Oh yeah, I talked to him. Yeah, I've seen him out here. He gave me a sandwich the last time you were out. Like, just more familiar and casual roles instead of these very formal and defined things, I think are better for this population in general, but particularly people who are kind of, you know, on the outskirts of the law and things like that, like where we just don't make as big a deal about the things they're doing all the time. And making sure that they attend to like basic nutrition and hydration, like, because you don't eat. It's one of the reasons I think sometimes people get into using meth on the streets is because it allows you to be okay not having as much food, and it helps you to maybe drink a little bit more. This is like a typical course of somebody getting involved with amphetamines is sometimes they start using it so that they don't pass out, or that they are more alert for whatever role they have in the world. And the role of somebody on the street is sometimes, you know, you don't want to get taken advantage of, so you might use a little bit just to like make sure your stuff doesn't get stolen, and stay up all night because it's less safe at night, and then sleep during the day. But then these types of things can, like, you know, snowball into like full-blown regular use.
That's a really big one. That is a huge one. I mean, I would say that's probably 70% of the reasons why people that are experiencing homelessness start using meth once they're out there is for that very reason.
Which is a great argument for one of the most successful interventions being housing first. Because I have seen this happen. I've seen this happen with people where you think that the way that they are on the street is the way they'll be in housing, and it doesn't always necessarily translate, because once they have somewhere to be, sometimes they don't drink as much because they don't need to. Sometimes they don't use meth as much because they aren't trying to stay awake. Like, yeah, I've seen people go into housing and they like go hibernate, you know, like sleep for freaking weeks at a time. They're just always asleep. You know, it's a lot of this is street coping skills.
To view the full discussion, visit the Harm Reduction SharePoint page and the Learning Department's Harm Reduction playlist on YouTube.